I'll introduce our next speaker. This is Dr. John Kryger. He is the Chief of Pediatric Urology at Medical College of Wisconsin, the Children's Hospital there, and he is an expert in bladder exstrophy, as you will soon find out, as well as with multi-institutional collaborations, and will be leading the charge next summer for the conference in Milwaukee. So welcome and thanks for being here.
Yeah, thank you for having me. It's a real privilege to meet with you. You're a passionate group of people who advocate well, and you stayed committed to this organization for so many years and decades, really. I remember Milwaukee hosting it once many years ago, close to 27 years ago. So I know you guys have continued to grow and build since then, and it made a big difference for patients. But I think most importantly, what you've done is inspired me and my colleagues to try to do a better job than we've been doing. And it's nice to follow up Jennifer, because some of the things she highlighted are what we're really trying in our way to move the needle. So I'd like to share with you how we do it. As you heard, I'm from Milwaukee, and I'm looking forward to seeing you all next year. How did she make that?
I don't
So we formed a group to try to answer some of these questions, a collaborative between Boston Children's Hospital, Children's Hospital of Philadelphia, and my institution, Advanced Medicine, and Children's Hospital of Wisconsin. And we simply call ourselves MIBEC. There's nothing clever to it, except that it's a multi-institutional bladder exstrophy consortium. One day we're like, we should have a name. Somebody said, I don't know, MIBEC. We're like, okay, good. And we went on to the next topic, and that was the end of our creativity. So we're a surgical collaborative, which is really unique. It's really hard to get surgeons from 3 major health centers to get together every time a certain surgery comes up and to travel to that community, work together, because you have to stop your life, you have to stop your practice, you have to travel to Boston or Philadelphia. And so it's a big commitment. There's a lot of cost in it. None of our institutions would have approved it. We just did this without asking, the old philosophy, what is it? Ask forgiveness, right? Not permission, right? That's what we did. We didn't ask for permission. I know some groups have tried to ask permission and it hasn't worked for them. And so we did it because we thought it would be incredible. And we're really happy with how it's working for us. We limit it to just select surgeons at each hospital. It's not the whole Children's Wisconsin group. It's not the whole Philadelphia group. It's just 2 or 3 surgeons at each hospital that we limit it to, because we want to maximize the exposure to a limited number of people, because exposure is very meaningful in complex surgeries. And our mission was really, what we wanted to do was standardize the Mitchell technique. We all knew Mike Mitchell. Mike Mitchell's from here originally. He's at Children's Wisconsin now. That's our relationship between me and Seattle. But he had achieved and accomplished so much, yet so many other people were not able to achieve what he had been able to do. So, and you can't just get it in a textbook. So we said, let's have Mike Mitchell come and operate with us. But we can't expect him to travel all over the world for every surgery. So we bring Mike in for whatever surgery we do, wherever it's Boston or Philadelphia. And in doing so, we were able to see Mike's technique and learn from it and standardize it so that, as Dr. Ahn said, we would have a meaningful database. It's not 3 hospitals each doing the surgery differently and trying to assimilate their data. It's 3 hospitals doing the surgery identically the same and including every single patient without, exclusion criteria, we call them, into a database that would somehow be, we hope, more meaningful. And in the process, hopefully we would promote and educate the advancement of exstrophy care for everybody. We would hope, we thought our model would inspire models across the country to form. And that we would have publications of our outcomes in national journals. We try to create a lot of teaching videos that others can learn from. We are certainly inclusive and open to anybody who wants to learn from our approach. And we are in the process teaching the next generation of pediatric urologists to hopefully continue to do it with a standardized technique and communicate, with us as experts in the field. So it was really, I have to give credit to Doug Canning for inspiring it, because for years and years, people talk about it. We should do this. We should do this. Yeah, we should do that. But Doug made it happen. Doug is the guy who picked a date and picked the people and said, we're all getting together. We're going to do the surgery. We're going to keep doing it together. He was that guy who made things happen. And our first surgery was at Boston Children's on a cold, snowy night, February 7th of 2013. So, but anyway, I remember that night very well. And so our approach is to standardize the surgery, as I said, to increase the surgeon's volume. So as Dr. Kryger said earlier, you might do 2 to 6 surgeries if you're a high volume center, but still, is that enough? 2 to 6 at our hospital though, and then I go and participate in, even a little more at Boston Children's and even a little more at CHOP. Well, now my exposure per year has gone up exponentially by collaborating with 2 other groups. And when you have a database, and Dr. Ahn said it, I was so happy to follow up with her, you can be nimble, you can make a more rapid assessment of the changes you make. We're going to do this way this time, guys, and then we can do it 6 more times over the next several over the next several months, and really see the impact of the little change you make in surgery, like, let's throw that stitch like this, and we're going to do it for the next 4 cases and see what a difference that can make. You need kind of a high volume database to make nimble changes, as she talked about, and then to review the outcomes in a validated database. So this is our team at Boston Children's Hospital. Dr. Bohr, big inspiration to all of us, hardest working man I've ever met in my life. Children's Wisconsin, it's my team that I've listed there. Children's Philadelphia, really inspired by Dr. Canning, who tragically passed away last year, which is sadness to all of us. But he had built really and inspired a great team of colleagues to continue his vision. And so we are MIBEC. And of course, the coach is Dr. Mitchell. Dr. Mitchell used to come and literally do the surgeries with us. But now, especially since COVID, it's limited his ability to travel. So we have great video conferencing technology. And we had done so many surgeries together that we're getting to the point where we each know what the next person's going to say or recommend. But we do video conferencing. We're getting back to being in person, but I have to admit COVID kind of derailed us a little briefly. But it's the value of a high volume experience. You may not see all the details on this slide, but what it says is, if you start at the top, greater patient volume in a medical condition leads to rapidly accumulating experience, leads to better clinical data, leads to forming dedicated teams, which leads to more tailored facilities, improved efficiency, greater leverage in purchasing, costs of information technology, faster innovation, better results, improved reputation, which leads to more patients. And around you go, this virtuous cycle, which really in surgery, volume, this is why volume is so important when it comes to being a surgeon, the volume of your experience. Just like any athlete, the volume of repetition of doing something makes you a better athlete or a better, whatever field, a better musician, whatever you want to be. And so when it comes to developing resources, we can develop a more dedicated team of resources. We have a great pediatric urology team, but we have a single pediatric orthopedic surgeon who does all our osteotomies. We have a dedicated team of anesthesiologists who know the exstrophy case and the anesthesia involved with it to be efficient. We have an intensive care unit team who knows what to expect when the patient arrives. They've been there, they've done that. They know what it's going to be like to care for a patient in a spica cast. We have a psychologist who helps support the families. We have a pain specialty team who know what exstrophy pain is like after surgery, and they've developed a methodology all their own for the exstrophy patients. And the nurses who are not surprised to see a patient in a spica cast with a suprapubic tube. So it all feeds on itself by them being exposed to it more often. So, part of our drive to want to replicate what Mitchell was doing is that achieving continence in exstrophy is really like the big panacea, right? That's the big thing we're all trying to improve, because so many things evolve from having better continence for patients. And yet retrospective studies are done, and Dr. Ahn highlighted why they're difficult. People do it differently. People don't always include all their patients, so you don't know if you're seeing their true experience. They have different definitions of continence. It just gets really hard to get meaningful interpretation out of the data. You don't have to read the details here, but it's just a smattering. One institution reports 15%. One reports 9% continence, one reports 70% continence. Are we comparing apples to oranges, or apples to apples here, or are we comparing apples to oranges? It's really hard to know. So we hope our database will be well-defined and very clear as to what our outcomes are. And this was all inspired by our drive to want to replicate what Dr. Mitchell was doing. He was a real innovator in the field of exstrophy. And he was describing a more radical dissection of the urethra and the genitalia, a more aggressive dissection of the bladder neck to reconstruct the sphincter, and to place the pelvic organs more deeper amid the muscle of the pelvis. And achieving really great continence outcomes. And so we wanted to reproduce that, is the bottom line. And we just created the most simple methodology we could, which is let's get together with Mike Mitchell and watch him do it time and time, as many times as we can. Some of the things critical to his philosophy is that with proper dissection of these structures, you'll hear him say this 100 times, the anatomical parts are all there. It's just, can you surgically put them together into the best functional outcome achievable, and to do it as early in life as possible so that the natural development can then just proceed as it would have had all the parts been put together to begin with. And one of those things is to get that bladder cycling, but that requires a sphincter muscle to hold the urine, that requires a urethra, that requires a bladder that is hopefully favorable to grow and develop. So there's a lot of elements that go into that are a lot easier said than done sometimes. So again, to reiterate, in our philosophy, critical elements are to achieve continence, you have to have good bladder capacity to achieve a dry interval. And so it's evident that achieving that bladder capacity takes years. And so doing the best possible surgery doesn't mean you're going to be continent by the time you're 4 or 5 and starting school when you want it. It takes a lot longer than that when it's been put together surgically. And I often tell my parents, that school age is such a devastating time, right? To send your kid to school who's not continent. And we all want that for our children, but I always tell them, your bladder doesn't know it's first grade and that it's supposed to be continent. Your bladder is living its own life and it's working on its own time frame, and And your bladder does not know that first grade starts in September. And I wish it did, but it doesn't. So equally critical to achieving dry intervals is those sphincter muscles that Dr. Gregorian talked about, the bladder neck sphincter, but also the pelvic floor sphincter. And that sphincter takes a lot of time to strengthen. And, we do pelvic floor strengthening exercises, but again, I tell my patients, you can have your 5-year-old child do arm curls all day, but he ain't gonna get a very big bicep muscle before puberty when he's 5 years old. But at puberty, when these hormones kick in, your child does arm curls all day long, you're gonna see some muscles develop. So certain things can only happen in the time frame that the body allows it. So pelvic floor strengthening is really powerful, but may not have a big impact until the hormones of puberty kick in, and that's a long time to wait, right? A long time for you who want it to happen yesterday already. So meticulous anatomic dissection to bring these parts together anatomically. And like I said, commitment to pelvic floor strengthening and behavior modification. Even with the best outcomes, you're going to be living on a schedule. And that's a big behavior modification for children, to live on a schedule. Their friends don't have to live on a schedule. Their bladders just subconsciously do what they're supposed to do. But we're asking this child, every 2 hours, stop what you're doing, whatever you and your friends are doing, leave your classroom, get up in front of the rest of the class and go to the bathroom. Kids hate to have to do anything different than their peers. Nobody wants to be different for any reason, even if it's going to the bathroom. So coaching, psychological support, behavior modification is really critical to the success of our philosophy. So collaboration. I've talked about collaboration with Boston and Philadelphia. Mike Mitchell said it well. Collaboration is a mechanism to learn from each other's expertise toward promoting the main goal of optimizing care and outcome for rare and complex patients with exstrophy. It was beautifully said. We've kind of embraced this frog. Take a good look at this frog. Notice the beauty, the delicacy, the symmetry of this frog, because we're going to come back to this frog later in the talk. So get a good look at it. We were inspired, at the time we were forming this paper comes out in the New Yorker by Atul Gawande about how you achieve your personal best as a physician. And one of his philosophies was coaching, and he said his principle, critical to have real-time active participation in coaching by surgeons with a follow-up group analysis and discussion. Yet surgeons traditionally don't do that. I mean, a lot of times it's the old school apprentice philosophy. You serve your time as an apprentice, you go off on your own, you hang your shingle, and you do things the way you were taught to do things. But you don't stay engaged with coaching traditionally in medicine like we're trying to achieve. So we have the best possible coach, right? You've heard the name Dr. Mitchell mentioned a few times today. So I'm grateful to have Mike Mitchell as a coach, and he's inspired a lot of people. And that's what he looks like in the operating room when he's coaching you. That's him and Dr. Canning actually having a pretty healthy debate about a certain step we needed to take. Exstrophy is the perfect model for surgical coaching. It's a rare disease. It's complex and requires a mastery of surgery to do it well, but gaining that expertise is really challenging to get the volume. So some of our earlier benefits, as I said, have been to have a team of consistent surgeons. I feel we do better teaching when you bring the collective wisdom of multiple surgeons into one room for your child's surgery in a city, that may be far from their home. I think it's very powerful for the patients to see our commitment to do well for their child. It's also powerful for us to step in a room for a complex surgery knowing I got Mike Mitchell on this shoulder and Doug Canning on this shoulder and Joe Bohr standing across the table from me. It's like, it's a very powerful moment, and in the process, we become really good friends too. And I don't take that lightly. That's been a great thing in my life that inspires me to continue to want to do more and do better and teach this philosophy to the next generation. So these are what the numbers look like from working together. Those first three columns show the numbers we were each doing individually at Boston, Philadelphia, and Wisconsin. Then we start working together, and you can see our number of experiences per year start to grow. I didn't have the data for 2022 together, but we've done over 100 classic bladder exstrophy repairs together. And we've done other surgeries related to it, cloacal exstrophy, epispadias, additional exstrophy bladder neck surgeries if we needed to. So we've had 174 patients over that almost 10-year experience there. And we've made over 100 trips to each other's institutions. So we're traveling a lot. And it's a high cost financially and personally, but it's kind of a mission of love for us. And like I said, the friendship really helps you. You'll want to go back to Philadelphia or Boston. And we've done some things with our post-op clinical pathway. For example, at Milwaukee, I think we really inspired people to look at our pathway because our patients are home in 5 or 6 days consistently after exstrophy repair without fail. And it's just the value of having a dedicated team who knows what to do, having patients who are mentally prepared for what to expect. And so I think we really reduce the amount of time they spend in a hospital or away from their home city when they travel to come to our institution. We have an 8-year follow-up study now that we're submitting for publication real soon. And we wanted to look at especially those patients that had at least 4 years of follow-up, up to 8. So just selecting the patients out from that 2013 to 2017 group, those are the ones that have at least 4 to 8 years of exposure. That was 46 patients in that window of classic bladder exstrophy. And, I have to admit, it's not like our surgery has created some magical breakthrough of continence. You can see here in that window, 7 of our, so we did lose some to follow-up, as Dr. Ahn said we try to avoid, but so we have 40 patients that we're able to still see and evaluate. Some came from outside the United States and have traveled back to India and whatnot. So there's some we lost, but very few, relatively. So 7 of the 40 are dry for intervals of 2 hours, and 5 of those 7 just void or urinate the regular way, and 2 of 7 are catheterizing. So I don't know that we've appreciated the full value of our approach yet, because again, I do believe you gotta get to puberty to really see the true value of what that sphincter strengthening will do for your continence, and the time for that bladder to grow enough to hold urine. But we've seen so many of our patients and Dr. Mitchell's all of a sudden become dry after puberty that we're really driven to keep pushing this philosophy. And if it's not true, at least we'll have an honest representation of what we did 10 years, 15, 20 years from now. We'll say, hey, these are our honest data. It is every patient, and maybe it was advanced and maybe it didn't, but it's gonna be something that contributes, I think, to exstrophy with some honest, meaningful outcomes that people can look at to guide the next generation of surgeons. We've really reduced complications. If you scroll down, so there were a total of 92 patients in over the 10 years. I only included the 40 that were in that window for continence. But if you include those, all 92 patients, we've had a fairly low incidence of complications. There were 2 patients that had a wound dehiscence. That was a big complication for us. Their urinary tract didn't come apart, but their abdominal incision came apart. We've had a number of fistulas where urine leaks from somewhere other than the pee hole. So those are repairable things. But I think we've really reduced the complications of the surgery. The one thing we have not seen is any damage to the genitalia, to the clitoris or the penis or the glands. That's been reported, and that's one of the more devastating complications one might experience, but no penile or genital injuries, no dehiscences where the urinary tract repair came apart. So I think we're doing a very safe surgery. So in conclusion, I think MIBEC is a collaboration that creates an honest, meaningful, high-volume database for a rare disorder. And we can incorporate assessment of changes we make in our surgical technique more nimbly or rapidly than other groups might be able to. As I said, no penile injuries. The girls in our group early on appeared more vulnerable to urinary retention. We've modified the technique a little bit. And we've reduced the incidence of bladder augmentation thus far. So none of our patients have had a bladder augmentation yet in 10 years. Now some may eventually come to need that, but thus far we have not augmented any of our patients of the 100 we've done. So Darwin also spoke of collaboration, and Charles Darwin said, in the long history of humankind, those that learn to collaborate and improvise most effectively have prevailed. So hopefully we'll evolve in the way Darwin said it is best. And we have some very satisfied patients and students and colleagues. And I view this frog as collaboration at its finest, because if you look at it, it's actually 5 women pieced together in collaboration to create that image of a frog. And I just think it's beautiful. And it really shows, what can be achieved if you work together in perfect harmony to see that. So thanks for allowing me to speak to you and sharing my insights and where I think exstrophy could go and should go over the upcoming decades. I can answer a few questions if you like, if there's time. Is there time? I'll take a question back here.
How much more complicated is it political exstrophy is possible?
It's a lot more complicated. So classic exstrophy is when the bladder and the genitalia are opened and exposed to the surface. And with cloacal exstrophy, they're not only open, but they're split into 2 halves, and erupting up through the middle is the intestinal tract that's also open and exposed. And so it's a lot more serious of an outcome. And so you have to reconstruct the intestines, put them back internally, and then reconstruct the urinary tract and get that internally. But with cloacal exstrophy, it's there's a lot of other anomalies like spinal cord anomalies as well, kidney anomalies that might lead to advanced kidney disease or even transplant. So you have more neurologic damage on top of the more devastating anatomical disorder, which makes that really a tougher repair entirely. But still, I hope we advance it. Working together again on cloacal exstrophy, I think is just as meaningful as classic bladder exstrophy. It's more rare, and I don't have high volume numbers I can share with you because it's even more rare than the classic bladder exstrophy. Yeah. Yeah. The average age is 2 to 3 months when we do the surgery. So we do not rush to close the exstrophy. That is part of our philosophy. And we feel that we have not compromised any of the outcomes by waiting a little longer. So by waiting 2 or 3 months, we can assemble our team so that we all meet in a city like Milwaukee. We have a little time to book a flight, to rearrange our schedules. And during that time, the child has time to nourish, to grow, to have exposure to hormones that naturally occur from the gonads, the testosterone, especially for boys with genital development. And for the parents and the family to bond and care for the child, before entering a big surgery, because the early surgery, as many of you know, is hard to be separated from a child that you've hardly had a chance to know. The child might be taken to a different city before you've even recovered from giving birth, going through a surgery that you can't be there for. It's got to be emotionally heartbreaking to go through that. And then you arrive just in time, maybe to see them before surgery, or they're in some sort of traction for the next 4 to 6 weeks. So those things are really important. And we think by delaying the surgery without consequence that a lot of those things can be resolved and hopefully eliminated from the care or the experience families have with their exstrophy babies at birth. So 2 to 3 months is when the surgery is, and now the ones I'm talking about follow-up are at least 4 years out from the surgery, up to 8 years.
You referenced that there were some patients getting dry, so.
Yes. So our patients from the MIBEC consortium have not gone through puberty yet, right? Because they're 10 years old is the oldest one we would have. But the patients that we've seen experience this are Dr. Mitchell's patients who we still care for. Dr. Mitchell here in Seattle is doing surgeries. We have his patients from Milwaukee, so we call those patients pre-MIBEC. They were repaired by Mitchell before we formed a consortium, and we're seeing that a lot of those patients that achieved continence didn't happen sometimes until puberty. That's where that information comes from. And it's a little bit anecdotal, because there haven't been great databases, back to that story about meaningful databases. That's why it's anecdotal. And even Mitchell's initial paper, let's be honest, he reported 74% continence, but were patients missing from that database? We don't have all the details on even that database. And so he's very forthright that the MIBEC database is going to be all-inclusive and hopefully be a more accurate reflection of his surgery done in a standardized way.
Hi, I've got a question. What is your experience with testosterone shots? And for new babies or even into puberty, have you ever done anything like that, and what's your experience with?
Yeah, so we do use testosterone. When we're doing the surgery, sometimes at 3 months of age, the testicles produce testosterone at around 1 to 2 months of age. They create a surge of testosterone called mini puberty, and it helps stimulate a little blood flow and development of the testicle, of the penis. But then testicles go into hibernation until puberty. So from 2 months of age till 13, they're just quiet, doing nothing. So if we don't feel like the genitalia are as robust as they should be for surgery, we boost it with a little extra testosterone. And I do that for bladder exstrophy, and I do that for a lot of other genital surgeries I do, unrelated to exstrophy, and I'm a big fan of it. I think it helps the outcomes a lot, in my opinion, and without consequence, in my opinion.
And so with the kids that are going to hit puberty now, when you wear that, so that those that are in that type, are you planning to implement testosterone for those soon-to-be teens?
No, because their testosterone will kick in. So we're waiting for puberty. The natural testosterone will kick in and do what the supplements did when they were in infancy to their genitalia. But you can't give testosterone too early. Consistently, you can give it a little bit to boost them for surgery, but if you do it that whole prepubertal period, there are consequences to overdosing testosterone in boys before puberty, because your growth plates will fuse and you'll end up permanently of short stature. So we wait for the testosterone to happen naturally. It would seem logical that we would want to start giving it sooner, but we can't because there's too much harm. We just give maybe one-shot booster dose before the surgery, but that's it. Yeah, I've probably gone. Well, yeah, I apologize. I'll talk to these topics, so.